well, really, if we're going to be doing this, we have to evaluate first. And I'll show you how to do that 'cause it's really quick. It's really easy. So to evaluate internal rotation, I'm just going to flex the hip up to about 90 degrees. The knees flex to 90 degrees. And then I externally rotate the femur, and I internally rotate just to see what the rotation's like. And if this were my hip, this would be awesome. I don't know if this is great for you because I have to test your other side. Could be asymmetrical. But compared to my hips, that's great rotation you can have on both internal and external. Internal, external. They seem about the same. So I'm not really too worried that we have an asymmetry. So let's say, let's actually do this like because I'm on the side of the table. Let's do it like this. We're going to put the patient's leg on the ground like this, or on the table. I maybe want the hip flexed a little bit less than 90 degrees or so, but this is, it's variable. The one thing you'll be able to tell if the hip's too flexed or not is while you're doing this, they'll actually feel it here versus back here. And if that's the case, let's say we started with the knee like this and the hip like this, and as I'm doing this, I asked the patient, are you feeling that in the front of your hip? If you said yes, I'd say, okay, now we got to extend that hip a little bit more. Okay. So you tell me, if you're feeling the front of your hip, we'll change it. Not a big deal. Second, this is a detail I didn't actually point out, but it's important. Watch the way I do this. I bring the leg to me. I don't bring me to the leg. We got to lean into the leg a little bit, and if I did that, that would just be really awkward. I didn't point it out in one of the classes. Everybody was falling over the tables. It was a mess. So there's a reason I'm not doing that. It's because, especially with these green tables, it's almost impossible for me to do anything. I'm locking out my knees. I'm leaning way too far over the table. It's really uncomfortable. I'm going to bring the knee into me. The foot's on the table. The knee's bent, and I'm leaning into the knee like this, using my body. I'm not putting my entire body weight in. If I was, I wouldn't be able to talk while I was doing this because it would hurt so much. If it was in my abdomen, I leaned in too much, it would be like that. If it was in my sternum, I'd be like, ow, this is really killing me. So I'm facing this way so I can control my weight. If I faced this way and I did that, it would be weird. I'd be putting way too much pressure into the leg, or I'd be forcing you into this abduction rotation thing, and then we don't want to do that. That's not part of this. So kind of like a 45-degree angle. And my force is going in line with the femur. So I bring the knee to me, I lean into the femur. Put a little bit of pressure, back pressure in the femur. It stretches the posterior capsule. Also, with my pressure on this bent knee here, I'm stabilizing the knee a little bit. So then to find the first barrier, I need to internally rotate the femur. So I lift the foot up a tiny bit. Watch. That much. Again, this is something I didn't point out. Everybody was doing it up here. If I did this and I extended the knee like that, now I'm actually leaning on the tibia. And I'm pushing the tibia posteriorly. I'm creating a weird shear force in the knee. I don't want to do that. So I don't need to lift the foot up much more than this, just so I can clear the table so I can move it out. See what I'm doing there? I'm rotating the hip, the femur out, and that's internal rotation. So let's find that first barrier. You don't really have one, but we'll pretend. So now we got the first barrier here in internal rotation. Now I have to try to tell a patient to externally rotate their femur or their hip. How do I do that?
Push back against your hand.
Move your knee away.
Go ahead and move your knee that way. That's not really external rotation, that's abduction. So this is a little bit tough. It's really easy if you do it the way I like to always tell patients to do PIRs. Just keep your appendage there, don't let me move it. And then I generate the motion. This is especially important because rotation is kind of hard to do for a lot of people. And what I found was I used to do this. I used to say, go ahead and try to bring this ankle in towards the other leg. And some patients completely get that. More patients didn't at all. They did some weird stuff. Some of them would just bend their ankle. Some of them would drive their knee that way. Some of them pulled their knee up. Like, I had no idea that people could mess that up as much. So the way I like to do it now, makes it the easiest, and it actually allows me to generate the torque, is keep your ankle there. Don't let me push it out any further. There we go. So I'm pushing out, but I'm also kind of pulling in on the knee to generate that torsion. If I just pushed out, they might contract their adductors. I mean, you did it perfectly right. Some patients might. Okay, go ahead and relax. I let patient relax. I go to the neck barrier. Where are you feeling that? Good, that's perfect. It's exactly, if they're feeling it posteriorly, perfect. Anteriorly, let's say I was doing that and you were like, feel that right there? This is what I would do. I'd extend the hip a little bit. Notice how I did that. I brought the hip down and I brought me down. So now the hip's extended a little bit. That's all you need to do, really. There might be occasionally, if somebody who has like really bad hip impingement, anterior hip impingement, or sometimes, occasionally, somebody with a hip replacement might get that same pain. It doesn't matter how much you extend their hip, they're always going to feel that there. This is not going to be a good setup for them. In fact, it's probably not going to be a good setup for that particular individual because they have too much anterior hip symptoms to do this. So this is a great setup to really stretch the hip into internal rotation, that capsule and also the muscles. After you do this on each other and you get this down, we'll talk about why you would want to do this and when you would want to do this. It's not, I mean, why you would even